Uh, Very good afternoon, and this is my proud privilege to be here to give my thoughts on a topic which is very, very relevant in the present scenario, and it's diabetes in young. So, all diabetes in young is not type 1. That's one line we must understand, and a false labeling makes really patient detrimental. Okay. So this I'm going to take you through a series of 3 or 4 cases which will make you understand how we go about these people. Now, first of all, diabetes in young means these children going to live for longer time with diabetes, more complications, more serious complications, and their compliance is poor, adherence is poor. So both the things are there. So more complications, more retinopathy and nephropathy, and they are not compliant. So we have to take the family into confidence and kind of make them self-empowered. So patient-centric approach has to be there. There's no conflict of interest in my talk. So let's go straight away on case one, a 15-year-old boy having recurrent boils for 2 months, polydipsia, polyuria, symptomatic, fever 1 week, weight loss 4 kg in last 1 month, fasting PP very high, A1C 10.3%, urine ketones positive. Family history, father is having diabetes. So this patient, if we look at, like straight away, this appears like a diabetic ketoacidosis and type 1. Now on examination, there are no signs of insulin resistance. BMI is 25, C-peptide 0.2, again on lower side, and anti-GAD around 10. Okay. So patient was managed on antibiotics, insulin infusion, and discharged. Now, such patients are generally, put as type 1. So, point is, please don't put the diagnosis. Treat them as an emergency. And after 10 days, when this patient came up, C-peptide had risen to 0.6. So, a point, of kind of, some beta cell are already there. And then fasting PP also came down, insulin dose was reduced, and patient could be managed only on metformin. Okay. So this is typically a case of a KPD, ketosis prone diabetes, which is basically type 2 diabetes. It is also known as flatbush diabetes. Okay. Now, there are certain pointers in this which are in favor and against. Okay. Because patient is having, C-peptide little more, so that goes against type 1, and there's a gradual improvement in C-peptide level. Type 2, we already know that anti-GAD antibodies may be present in 10% of type 2 diabetic patients. So anti-GAD antibody levels are also important, and this is around 10, which is little high, not very high. Okay. So we can see here in type 1, generally anti-GAD antibodies are more than 30. LADA is age more than 30, so that is not the possibility here. So basically the confusion was type 1 versus type 2 in this patient. And there, basically, type 2 diabetes is going up in recent past because of obesity. What I want to convey, that if this patient, if we would have put the patient label as type 1, patient would have been on insulin, and that would have been detrimental, overall, and patient could have been managed with oral. So the points in favor here was, father was having diabetes, C-peptide not 0, it improved after treatment, which is against type 1. Antibodies goes in favor, but not very high. Okay. So again, I'll repeat that don't label, take your time, treat the patient, and take 2 to 3 weeks time to label the final, diagnosis. So type 2 is on the increase in younger people, and there was a study in All India Institute of Medical Science, and these children, they have more of nephropathy and more of retinopathy. So coming to case 2, the 18-year-old girl having type 1 diabetes was diagnosed 10 years back, on basal bolus, UTI for last 2 months, A1C 8.5, and blood pressure 130/84, skin tags plus, C-peptide 0.3. Okay, so here again little on higher side of it is not 0, it is not on the lower side, it is in between the 0.3 to 0.1. 0.3 to 1, and LDL is 110. So this is another case which tells us that type 1 diabetic patients, when you give treatment now, since the lifespan has increased, and they also start taking junk foods and all, so they develop some features of insulin resistance. Means it is a dual or double diabetes. It is mentioned in the literature that type 1 diabetic patients, they may need metformin and even SGLT2 inhibitors as per NICE guidelines can be given. So type 1 diabetic patients who have BMI more than 27 on insulin and not getting full control, there the role of SGLT2 is there. Obese or overweight type 1 diabetic patient. So we have type 2 diabetes in younger people who can present like type 1, very common, and then dual or double diabetes. Now let's come to another case, a 15-year-old girl having, polydipsia. These are like when children come, these are common presentation. The symptoms are, too much. So patient here, again A1C is 8.2, ketones are absent, mother is having diabetes, okay? Tricky situation, BMI 20. So this also appears. What I want to say, that we used to say that this is not common in India, type 1, because we are not thinking. We won't see what our mind doesn't know. Okay, so here the small pointer goes towards MODY. Means the patient is thin and mother is having diabetes. So we should not again label. I'm not saying it is, but we should not label a child presenting like type 1, but putting as type 1. Don't label this. So patient is on basal bolus, A1C is 8.2. Okay, so you may increase the dose. But if you think it may be MODY, patient may be controlled on sulfonylureas. Is that okay? So what I want to convey, that take a detailed history now. So since mother, and we know MODY, there's a autosomal dominant 3-generation transmission. So patient's sister, mother is having, and then maternal grandmother, history is to be taken. Okay. So in this patient, C-peptide is 1.0. So this again goes against type 1 diabetic patient. That's how we diagnose. So lean people, C-peptide relatively normal, on insulin, not well controlled. So think of something else. So when this pedigree charting was done, and we can see here, this is the patient. Patient's sister was also found to have diabetes, 1. Patient's mother, I told you in the history, okay, because mother got the patient. So my mother was having diabetes, even mother's sister, okay, and then maternal grandmother. So the point is that only history can. Ultimately, you have to do genetic testing. But again and again, what I want to emphasize, don't be in a hurry to diagnose. We will have so many cases who are wrongly put as type 1, who are actually not type 1. So we say MODY is not common, this is not common, because we are not thinking. We are putting the diagnosis without even investigating the patients. So this, patient, when this, we know very well that when MODY is there, the glimepiride sulfonylureas are very effective, monogenic diabetes. So when glimepiride was added, A1C, started coming down. So this patient was wrongly put on insulin. So unnecessarily we are giving insulin to MODY will be really not very useful, okay? So in monogenic, diabetes, we have, one is MODY. We have 14 or 15 types of MODY now, and MODY 3 is more common in India. And then we have other type also, neonatal. Even neonatal diabetes is also, it's that small child within 6 months of age, sulfonylureas are effective, okay? So these are all known things, but what I want to say again, if our mind doesn't know, we won't see that in the patient. So these are different types of MODY. I won't be going into detail of this. So generally, there's a defect in the beta cell function, but C-peptide are not 0. And then age is less than 25, autosomal dominant, and can be managed without insulin, okay? So as you know, so Modi is not that uncommon, okay? But the only thing is we are in a hurry to put the diagnosis in first or second visit. Don't do that. Now, another case, a 23-year-old gentleman comes to us with diabetes, a little pain abdomen off and on, having loose motions, and OAD, because again, 23 we take as all 23 as type 2. You know, we divide everybody as type 1 or type 2. That's not correct. So there's no family history of diabetes, non-smoker, OAD 2 years, and poor control, A1C again, anti-GAD negative, okay? Now, if someone comes to you with pain abdomen and it appears like type 2, think of FCPD, because if there's a pancreatic disease, pancreatic enzyme deficiency also occurs, and that leads to, you know, loose motions. So here we can see that, you know, BMI this much, urine ketones absent, and on abdomen grade 1 hepatic, you know, liver, fatty liver. On X-ray, multiple pancreatic calculi we can see here. These are the calculi. You can see these smaller ones. So this is a FCPD, case of FCPD, okay? Now, FCPD versus normal, you know, pancreatic disease, in FCPD there's exocrine deficiency also. So we have to supplement these children not only to control diabetes, they have to be given insulin, one, because endocrine deficiency is also there, but pancreatic enzymes like creon, I mean, all these should also be replenished. And calorie may not be restricted that much because they're already, you know, having, you know, enzyme deficiency. So normal calorie, more protein, and they have to be on insulin, and this is FCPD, which is again quite common, especially in southern part of India. Fibrocalculus pancreatic disease, which is, we call it as type 3C also, you know, as a classification. Now, there's another, which I have not got any case. This is MRDM, and it was in like last year IDF. You know, as per IDF, you know, they have now come out with type 5, IDF 2025 by Dr. Hawkins. This lecture was there. So MRDM, malnutrition related diabetes, now there is an insulin secretory defect. And it is, again, it was way back in 1985 and 88, Dr. MMS Ahuja, Dr. Tripathi, like this was there. But it got declassified. In 85, like it was officially classified, and then later on, 1999, it was dropped from the classification. Again, now in 2025, they have got it back, okay? So these cases we've been seeing in the past, like our mentors, seniors, they have already, you know, came out with such cases, and it is really, you know, little, like protein deficiency leading to, because like any malnutrition, even pancreas will get affected if there's a protein deficiency. So it is a calorie protein deficiency related diabetes. So overall in diabetes in young, there can be type 1, it can be type 2, it may be MODY, it may be FCPD, it may be LADA, it may be malnutrition related, it may be GDM, it may be endocrine causes, maybe genetic syndrome, and neonatal you know, mitochondrial defect. So there are so many, so don't be in a hurry. The first line is that all diabetes in children is not type 1, that's one. Don't be in a hurry to diagnose. Treat the patient, take your time, take a good history, and then get some investigations done, and then label. Because once you label, it's very difficult to remove that label. You know, it's taken as, I'll take just not more than a minute more. So this is basically, you know, it's a complicated algorithm, but I will, you know, don't go by this. One is family history. So history is very important, one. Second is urine for ketones, 2. Third is antibodies, and fourth is C-peptide. These 4 things can make things very, very clear. History, urine ketones, C-peptide, antibodies. Okay. So takeaway message is very clear. That diabetes in young is very common, and it may not be type 1. Always there's a diagnostic dilemma. Treat the patient, don't put the diagnosis, take your time. Proper clinical history, which is in times of, we used to call intelligent people, as separate. Now that is also becoming artificial. So what I want to say, that this intelligence should remain with us. History taking cannot be done by, AI. And, if you miss something on history, you will lose everything. Okay. So pedigree charting, in case if you find Modi, challenges are there, because children, we have to give more importance than adults. They have to live longer, more complications, fruitful life, productive life years. So awareness, education, intensive counseling is the hallmark, and don't be in a hurry to put diagnosis, and take your time. Thank you very much.